Hi, everybody. Good evening. We're going to give it a few more minutes, and then we will begin.
Can I suggest a question that I'd like to ask?
Sure.
I work in midwifery. A lot of women are calling in COVID positive, and some people have mentioned taking aspirin. I didn't see anything on the CDC guidelines about that, and the midwives were wondering if that's something that's recommended, a baby aspirin, or if it's not recommended.
Okay, Rifki, that's a great question. We're going to probably pose the questions after the presentation, but definitely if you can type it in the chat, and then we can ask Dr. Lisker when she finishes.
Okay, thank you.
Of course, she's definitely going to touch upon pregnancy though. Okay, going to begin in 1 minute. Just waiting. Okay, Dr. Lisker, are you ready?
I'm ready.
Okay. 1 second. Louis, do you mind admitting people that come in? Thank you. Okay, welcome everyone, and thank you for tuning in tonight to an exciting Refuah University presentation. Can someone just speak to see if they can hear me? Just want to make sure I'm heard. Everyone can hear me? Okay, good. Okay, thank you. For those of you that are joining us for the first time, Refuah U is our new organizational-wide professional development program. Our goal and our mission is to create relevant and mindful curriculum that brings together speakers and other creative content to encourage personal growth, both clinically and educationally. That said, if you have any specific requests for upcoming programming, we really encourage any and all feedback, so do not hesitate to reach out to me directly. We are honored to have with us tonight Dr. Geeta Lisker, who will be presenting COVID clinical updates. Dr. Lisker is the founder and director of CROWN, Coronavirus-Related Outpatient Work Navigators program at Northwell Health. To date, CROWN has treated over 2,500 COVID patients at home. In recognition of her work for CROWN, Dr. Lisker was awarded recently the 2021 Innovative Professional Award by the Barrel Institute. She is also the director of the Respiratory Care Unit at LIJ and a professor of medicine at Hofstra Northwell Medical School. As you can clearly tell, Dr. Lisker has been at the forefront of COVID-19 outpatient and inpatient therapeutics from the onset and has truly been a leader both professionally and within her community in guiding patients and the community at large during this pandemic. We are very, very thankful she will be sharing both her experience and vast knowledge base with us tonight. So there will be time at the end of the presentation for questions. Feel free to write them in the chat when they come to mind, and I can field them to Dr. Lisker at the conclusion of the night. Okay, so let's jump in. Dr. Lisker.
All right. Hi. Thank you so much. Thanks, Leora. Can you see my screen? Is it shared?
Yeah, we can see your screen,
Okay.
but you're not on the PowerPoint yet.
Sorry, 1 second. Let me just see what's going on. There we go.
Perfect. This is great.
Okay, fantastic. So thank you so much. Really a pleasure to be here. I will, one disclosure is that I do run the program for Northwell, and I do work at North Shore and LIJ. But unless specified here as a Northwell slide, which some of them will be, what I'm expressing is, I guess, my own research and my own thoughts. I do not speak on behalf of all of Northwell Health. I have to say that. Thank you. Okay. So really, this is going to talk about a COVID update, which is essentially, in today's world, Delta. So this is a graph for New York City that ended in August 14th. And basically, you can see the the B.1.617.2 variant, which is the Delta variant, which is started out, creeping over the winter and over the fall. And then right around here in mid-June, it really just took off. Sorry. It really just took off at mid-June. And so as of August 14th, based on the random testing that is being done by the Department of Health, basically 99% of all COVID that is identified in New York at this time is the Delta variant. So we're really not talking about anything else anymore. Delta is all that's left. And this is just a nice graphic depiction of that. And the reason that it really took over, as you can see from here, is that it's much more transmissible than, meaning much more contagious than the original version of the Alpha variant. So if you're looking at this, whereas moving to the right is more contagiousness, moving to the top is more deadly, fortunately, the Delta variant has not shown itself to be any more deadly or more dangerous once you're infected with it than the original version. However, clearly it is significantly more transmissible, now somewhere in the level of chickenpox, meaning it's more contagious than the flu. Second now only to measles, which is the most known contagious virus that we have. And then of course, the other thing that Delta does, aside being more contagious in general, is whereas children were really spared much of the first half of this with the original variant, is that Delta does seem to be much better at infecting children. Again, not that it's more virulent, more dangerous in the children. It's just by the mere fact that there are so many more children being infected, there naturally will be more children getting severely infected, just as a percentage. So that is that. The good news is, and really just at this point, one of the main takeaway points is that the vaccines are working despite all the breakthroughs. And what I do is really the canary in the coal mine, because what I do is I start getting we start getting referrals for outpatient cases. And we did definitely start, whereas in June, we thought we were home free. By July, it was clear that we were starting to get more referrals and definitely more breakthrough cases. Although I had my first breakthrough case in a vaccinated fellow cardiologist, in February. So the breakthrough cases were occurring, but clearly they started occurring more. But still, the vaccines are doing a fantastic job, and that's a very important message. There are a million studies out there. I'm not going to show all of them. I'm really just showing the ones that I thought were really the key that highlights most of this point. This is from the MMWR Weekly. So this was the site for New York COVID cases, May 3rd through July 25th. And anything I'm showing now really is going to be essentially including June and July, because including things that are pre-Delta at this point are really irrelevant. But this was published on August 27th. And this is a number that gets quoted. A lot of people ask me for the source in looking for the VE, which is the vaccine efficacy. You'll see that over and over again for fully vaccinated New Yorkers. And the key was, yes, the vaccine efficacy against new infection may have declined from 91.7 to 79.8%. So that, yes, clearly there were going to be more breakthrough cases. The vaccine efficacy for severe infection requiring hospitalization was still greater than 90%. And overall, that number at the box at the bottom is, basically 0.0017%. Which, in other words, 0.17 per every 100,000 people fully vaccinated were getting hospitalized, even with Delta. So the point was, we're definitely getting breakthrough infections, but it's really become now a livable infection and not as such a deadly infection if you are vaccinated and have an immune system. Obviously, this is a different disease for the immunocompromised, and it's totally right now a different disease for the unvaccinated population. Here's just another graph that shows this goes through July 24th. It starts in January. So again, these are hospitalizations. Even though the top line, I'm colorblind, so I'm never going to use colors. I apologize. I'm just going to use top and bottom. But whereas the number of breakthrough infections were still clearly starting to go up in the vaccinated, it was the dramatic increase in hospitalization was almost completely in the unvaccinated. So this, to me, is the summary of what we know about the vaccines and Delta. They definitely decrease, probably in the order of magnitude of 10 times. You're 10 times less likely to get reinfected sorry, to get a breakthrough infection with Delta if you are vaccinated than if you're not. Even if you do get the breakthrough infection, you are significantly, even more significantly less likely to get a severe infection. And it is really almost unheard of. It happens. I'm not saying that it doesn't, but it is surely, again, basically 0.17 out of 100,000 of risk of hospitalization and death if you have a normal immune system and you are fully vaccinated and you get a breakthrough infection. There are, of course, cases that we've had in the ICUs, organ transplant patients who are fully vaccinated, severely immunocompromised patients who never made a response. North Shore had one death in a person who had metastatic colon cancer diffusely, died of COVID, although it's hard to say what was what. And we've had one or two that are a little bit more troubling. People in their 70s who only have hypertension, for example, who didn't die, but they did end up in an ICU. But these are a handful that you can pick out. For the most part, that's not it. We also seem a pretty good idea right now that even those who get infected with Delta after being vaccinated, they may get infected, but their viral shedding and therefore their time of contagiousness is clearly much shorter. So although right now it's still the 10-day isolation period, we definitely are shedding for less likely. And so in general, if you're much less likely to get it and you're contagious for much less time, you're much less likely to spread it. And a key point at the bottom, vaccination decreases the rate of breakthrough infections for those who have had prior COVID infection as well. And, there's a lot of talk, and I have it later. I had COVID already. I have my antibodies. I don't need the vaccine. It's not to say at all that natural immunity does not provide protection. It 100% does. However, getting a vaccine on top of that definitely provides a greater level of protection against reinfection, and we know that. So actually, this is one point. This is the Kentucky study that was published in August, which again looked at people who were had prior COVID infection, vaccinated and not vaccinated, and those who were unvaccinated had prior COVID compared to those who were vaccinated and had prior COVID, still had a 2.3 times higher odds ratio of getting reinfected. So that's great. You had COVID, you have some natural immunity, you get a vaccine, you have even more immunity, and you're even less likely to get a breakthrough infection than those who simply had natural immunity from having had COVID, particularly if you had it a long time ago. I'm bringing this up because everybody seems to talk about it. It was in the news, it was spread on every WhatsApp group that I have, despite the fact, and the key point here is this underlined at the top, and I think it's in blue, so don't get me wrong. This was something that was published and everybody's talking about it. Just as the side point, this was not yet peer reviewed and it was not yet published, and everybody knows that after a peer review, studies can be totally turned upside their head and found to be irrelevant. But even if it turns out to be good, the study that came out of Israel comparing the natural immunity to vaccine-induced immunity was totally misquoted in so many places, aside from the fact, again, even if it, after peer review, even if it stands, there's no question about it. But let's just look at what they did. They looked at 3 groups. So one was those who had natural infection plus no vaccine. One was previously infected and a single dose of the vaccine. And then one was with 2 doses of the vaccine. Previous infection in this case meant that they were infected on or after January 1st, 2021. So when people are talking about this greatly improved natural immunity for those who had actual COVID infection, that was referring to the ones that had it after January 2021, so within 6 months. And yes, they did have a much lower rate of breakthrough infections compared to those who were vaccinated at the same time. Once you started going back to infection from March 2020 through January 2021, it was still there, but it was much more modest. So natural immunity was definitely starting to wane as well. And again, a key point, if you look at the last line, is even those who were both previously infected, if they were given a single dose, because that's what Israel does, a single dose of vaccine following natural infection after January 21, so essentially the second shot, protected them even further. And so there's no question, and I'm not a policymaker deciding whether that should be 1 shot, 2 shot. Eventually in Israel, my guess is that it'll end up being the second shot as a booster, but clearly getting at least 1 dose of a vaccine, if not 2, after recent natural infection adds extra layers of protection. I put in a slide on vaccine safety. I'm not going to go through, again, I'm not going to go through all of it. I've heard almost every anecdotal story from almost every ethnic group that I have treated. LIJ is on the border of Queens and Nassau County. Queens is the most diverse place on planet Earth. There are over 150 languages spoken. So, and on top of that, of course, I'm very active in all of the Orthodox Jewish communities, the Hasidic communities. I come from a Hasidic background. I have heard the cultural, basically dogma, the cultural conspiracy theories from everyone from the Dominicans to the Caribbeans to the Hindus to the Russians to the Jews. I mean, everyone has slightly different. We actually have a colleague right now down in Barbados because they needed help, and there's a whole different conspiracy theory. But, oh, sorry. The fact is that there are over 6 billion doses of the vaccines that have been given in the world so far. Over almost 500 million doses were given in the United States alone. Sorry. I'm putting up there just some of them and the ones that were published in the most major reputable journals. So that, the Israel recently published in the New England Journal of Medicine on September 16th, their experience with almost 1 million of the Pfizer vaccines. It was not associated, and again, the one, of course, that everyone's talking about from this is myocarditis risk. The myocarditis, which first of all is a treatable disease. Nobody has actually died of this in the case in these events. But the point that other people are not bringing out is that COVID infection itself increases the risk of these inflammatory diseases. And so while there was a 1 to 5 event in the 100,000 after receiving the vaccine, this and other things like lymphadenopathy were not any higher than that in those people who got COVID as well. Excuse me. And so this tiny infinitesimal risk of the vaccine was no different from the risk of getting a disease from which you were protecting. And obviously it protected you so much even further. There's a lot of talk about fertility, a lot of talk about pregnancy. I'm just putting up a few things here. This is the first one is from JAMA Network. Again, just now from September, where they looked at over 100,000 pregnancies that were spontaneously aborted. So basically 100,000 miscarriages that were done. And they looked at them to see if there was any difference in rates among those who were vaccinated versus unvaccinated in these miscarriages. And they were not. The spontaneous miscarriage rate, which happens, was exactly the same, whether you were vaccinated or not. There was nothing to suggest that vaccination was associated with an increased risk of the spontaneous miscarriage. In June, the New England Journal presented the original preliminary data on almost 36,000 pregnant women, again, with no danger to the fetus, no danger to the mother. And I cannot, at a point that I have to stress, so I also do, inpatient, and I am a critical care physician, and the sadness of the stories, it is a known fact that pregnancy increases the risk of severity of disease with COVID. For the fetus, for early term labor, for severe pneumonia, for mechanical ventilation. And so pregnant women are at a much greater risk of severe disease if they develop COVID, and there is absolutely nothing suggesting anything but safety of the vaccine in pregnant women for both them and for the babies. There's another talk, and I put it up here. This is from the British Medical Journal, just from now, again, from September. I've heard this particularly from, and it's funny, I hear the stories from people when they get sick with COVID, and they're explaining to me why they didn't get the vaccine after coming to me for help, because now they're on oxygen and they're feeling bad. And anecdotally, there's a lot of stories out there about women who are complaining about changes in menstruation after getting the COVID vaccine. So number one, that is actually being looked at to see whether or not that's actually anecdotally true, or whether, because so many things can affect the menstrual cycle. So whether or not it's the stress of the pandemic itself, whether or not it's the fear and the stress that's being worked up about getting the vaccine. But even in so far, anyone that's looked at it, the periods do return to normal after several cycles. There's been no at all, and this has been looked at, looking at effects of the COVID vaccine on fertility. And this has been looked at quite a bit. And actually, there's been nothing to suggest that in any way, shape, or form, despite somebody who started this terrible rumor baseless on nothing, that it affects fertility. In fact, the only thing that we do know is that COVID infection in men can reduce sperm counts and therefore actually decrease fertility. That being said, the NIH, there are actually current fundings. I think Hopkins is running one about looking specifically at menstrual cycles post the COVID vaccine. So this is still being looked at, but all data is saying that there is no risk of infertility, there is no risk of miscarriage, there is no risk to the fetus, and there is no risk to the pregnant woman, and there is overwhelming risk to both the fetus, obviously, if the mother gets sick, and to the mother if they get COVID when pregnant. And I'm not going to go through my sob stories. Unfortunately, we have too many. We have some who thank God made it out okay, but it's been bad. The American College of Obstetrics and Gynecology clearly recommends that both pregnant and breastfeeding women be vaccinated against COVID. If you are vaccinated while you are pregnant or breastfeeding, the antibodies actually do transfer over to the infant, which is a nice secondary benefit. Infants, even newborns, I've had one as young as 7 days, are getting infected with COVID. They're obviously too young to get vaccinated. Like I said, my youngest patient, well, he wasn't my patient, but was the son of a postpartum woman who I had to admit to the hospital, almost needed a pacemaker and needed oxygen because she didn't get the vaccine because she was pregnant. And, a day after she delivered, developed severe COVID pneumonia, and her 7-day-old infant tested positive and had a runny nose as well. So the risk of COVID during pregnancy is known. The safety of the COVID vaccine has been demonstrated, and a nice effect is that you can then get antibodies in the infant as well. Okay, switching gears a little bit to the topics of the days. So COVID vaccine boosters and immunocompromised dosing, and those are two different things. They are not the same. So for patients who are immunocompromised, and you can see the decision, the definitions over there. So, but basically, if you're on chemotherapy, if you receive any immunosuppressive medication, if you're a transplant patient, HIV patients, anyone who on high doses of steroids, you're considered immunosuppressed. So immunocompromised patients, they're not even being, it's not called a booster. They should be simply receiving 3 doses of the vaccine. So, and the third dose should be 28 days after the second. So if you get your Pfizer dose and you're immunocompromised, you get 1 dose, you get another dose 3 weeks later, you get another dose 28 days later. Obviously, if you were vaccinated in April, it's not going to happen at 28 days, but these people should be going and getting their third dose. And if they had Moderna, they should get Moderna. And if they had Pfizer, they should get Pfizer. It's not a booster. So while Moderna is still actually not approved as a booster, that doesn't apply here. This is just a third dose of the vaccine. And we do strongly recommend immunosuppressed patients to go get the third dose, because we have definitely seen that the immune response has not been very good to the second, and there is evidence that the third dose does help. So that's the third dose for immunocompromised patients. The next is the actual booster, which was recently approved here. Obviously, everything that the CDC and the FDA looks at here comes out of data from Israel, because they're ahead on everything, and they're the first ones that started giving the boosters. So this, again, was just published in the New England Journal of Medicine in the middle of September. And basically, if you read the top, in early June, Israel had thought, okay, great, COVID is gone, with their pretty good 70% vaccination rates. And then by the end of August, they were getting more than 10,000 a day. And there were, the possibilities that were looked at. So one is, I like to quote Dr. Farber, who's the chief of infectious disease for Northwell, which is the virus that we were vaccinated against is no longer in existence, right? So we were vaccinated against the Alpha variant, and now here's the Delta variant. And although there is some cross-reactivity, obviously it's working, but it's not the same virus. So the booster is not going to change that. The booster we're getting now is still to the same initial strain. Hopefully, that's going to change. And like the flu shot, it'll be tailored to the proper variants. But the other thing that was happening was that there was waning immunity with time. And also with the waning immunity, the Delta had figured out a way to get around it. And so therefore, they basically decided to open up the boosters after 5 months. And what happened was, in this particular study, was for patients over 60 years old, that once they got a booster shot after 5 months after the second, the rates of COVID and severe illness substantially went down. And that's generally at 10 days after receiving your booster is when you really hit the full effect of the new added layer of protection for breakthrough infection and for severe infection. Graphically, I mean, this is also the out of the Israeli data. If you're looking at obviously you can see the third one, I think it's yellow, that once you got the booster shot, your serious cases went down dramatically, obviously compared to the unvaccinated, but also to those who had gotten their just 2 doses. Once they got the 3rd dose, especially in the older population, the change really became dramatic. What Israel is doing, and again, this is also to answer some of those claiming that, look, in Israel, they're not vaccinating people who had natural immunity. It's not true. So Israel has actually changed it as of yesterday. In Israel, being fully vaccinated now means 3 shots. So as of yesterday, for those people who had been either vaccinated more than 6 months before, were going to lose their green pass unless they got a 3rd shot. And even people who had previous COVID and recovered needed to have 1 booster shot in order to get their green pass. So there is no one in Israel right now. There's no such thing as I had COVID, therefore I don't need a vaccine. Right now it's 1 shot if you had COVID, and it's 3 shots if you didn't. And actually the part on the bottom coming out from AIM Health is interesting because it affects, this was brought to my attention by people who called to ask me. These are people who have kids in Israel for the year. It's actually going to be very interesting how they handle this, because not only are they saying that you had to have had your 2 shots, but your 2nd shot had to have been within the last 6 months in Israel. So people are calling me up and saying, well, my kid got his 2nd dose on August 1st in New York, and now Israel is forcing him to get a booster only 2 months later, essentially. So that's, I'm not exactly sure. As of yesterday, their green passes would have expired. So then these kids might end up with boosters only like 2 or 3 months after their 2nd shot. But that's where that is right now. The CDC guidelines. So where are we? We went through a lot of times. The FDA recommended one thing, the CDC recommended something else, and then the director, Walensky, came out and put her foot down and said, yes, this is what we're doing. So the current CDC guidelines is who is eligible for a vaccine booster. So it's anyone who got their 2nd dose more than 6 months ago, and meets the following criteria, which is a lot of people. Anyone over 65 or older, and then any adult 18 or over who lives in a long-term care facility, who has underlying medical conditions, which is almost any medical condition, and who work in a high-risk setting or live in a high-risk setting. So anyone 18 or older, so high blood pressure, asthma, and pretty much any underlying medical condition. If you're 18 and over, and you were vaccinated 6 months ago, you are eligible for a booster. The list of occupations that are at high risk, that even if you're 30 and healthy, any first responders, healthcare workers, educational staff, that includes teachers, support staff, daycare workers, therapists, piano teachers, as far as I'm concerned, food workers, correction officers, we probably don't have a lot of correction officers and postal service workers, grocery store workers. So any of these people 18 and over are eligible for a booster if it's more than 6 months. Another very important point. So officially, the CDC statement is for Pfizer. So the official current booster recommendation is only for patients who received their first 2 doses with Pfizer are eligible, according to the CDC, 6 months later to receive a booster with Pfizer. There, as of now, is no approved Moderna booster. You can get Moderna as a 3rd shot if you're immunocompromised, but there is no approved Moderna booster shot because they're still debating whether it should be the full dose or half dose or whatever they're going to do. So officially by the CDC, you can really only get a Pfizer booster if you had the Pfizer vaccine. However, and so people, people are calling and saying, my doc, I can't get the booster. It's not true. Because the COVID vaccine, the Pfizer vaccine, is now FDA approved, any physician can prescribe it off-label use for anyone who they think it is appropriate. So if you are a provider and you have a patient who meets criteria for a booster who received Moderna 7 months ago, you can advise them to get a Pfizer booster off-label, and you can write a prescription and they can take it to Rite Aid or wherever it is and they can get it. So I myself, any of my Moderna patients who I think need a booster, I'm telling them to go get a Pfizer booster. Okay, that's it for boosters. Sorry, I got a lot to say. Next, I'm just coming on to where treatment stands right now. Okay, so I'm moving on to the monoclonal antibodies as treatment. we've been using them since December. They've really become much more popular a lot now. Monoclonal, not really, it's monoclonal, but now it's 2 monoclonals. Used to be originally we were using the Eli Lilly, which was 1. With the emergence of the Delta variant, that became obsolete. We now use the REGEN-COV2, which is a combination of 2 monoclonal antibodies, which is a really, fortunately, it's a fantastic treatment. This was the original study on this. They looked at patients who had 1 or more risk factor for severe disease. Of note, in all of the studies, actually, the treatment was given within 7 days. This is 4,500 people. And there was a 70% risk reduction in the combined outcome of hospitalization and death. I mean, that's fantastic, right? These are in high-risk people. And it also shortened duration of symptoms by approximately 4 days. That's in the graph. So there's no question that the monoclonal antibodies are doing a great job at keeping people from getting severe disease, being hospitalized, and probably less importantly, but still important, shortening symptoms. But that's not our goal. The key here is that this was in unvaccinated people. So no question about it, in unvaccinated and probably in immunocompromised, this does it. The benefit of monoclonal antibodies in people who are vaccinated is just unknown. It hasn't been studied and it's unknown. And one of the reasons that it's likely not to make such a huge difference is from one of the earlier slides, that is, if you're fully vaccinated, your chance of getting hospitalized from COVID is, less, is 1 in 100,000. So making a difference in decreasing the rates of hospitalization in people who already have such a low risk of hospitalization is going to be tough to show. And so we just don't know the answer to that. And I can give you my strategy afterwards, which is basically not everybody that has a breakthrough infection needs MAB or will benefit from MAB. So, and I have a couple of slides later that the criteria for getting MAB has also really been loosened so that many, many more people are now eligible. We're also getting shortages for this reason because everybody is getting it. So whereas, your 85-year-old fully vaccinated, person who has diabetes and coronary disease and high blood pressure, that's somebody, even though they're fully vaccinated, I could make the argument, well, they're still at high risk, they're still the highest risk among vaccinated people for hospitalization, they should get MAB. If you're 40 and you have a BMI of 26 and you're otherwise healthy and you're fully vaccinated, should you be getting MAB? Probably not, because it's really not going to make a difference. And certainly the supply is no longer infinite. Again, this is my opinion and my approach, just to be clear. The next thing, again, actually, is so monoclonal antibodies as prophylaxis. And this was something new that was approved in August, and it was based on the data from this study that was just published a few weeks ago, again in the New England Journal of Medicine, looking at monoclonal antibodies with the Regeneron after people had close contact exposures. So they took, these were all people who did not have prior COVID histories and did not have vaccines, who were household contacts of people who had COVID. And they looked at a whole bunch of them. There were 1,500 people. And they gave them prophylactic monoclonal antibodies. And without a doubt, if you can see that, the p-value was very impressive, and 1.5% versus 7.8% of them developed COVID after receiving the prophylaxis. So, and they did, even those who did actually still get it, actually were not as sick for as long. So giving monoclonal antibodies as prophylaxis after an exposure works. Again, this is not approved for everybody. Who is this approved for? So let's just go through that. So in August, emergency use authorization was started actually practically in September, was given for monoclonal antibody prophylaxis, but only in very specific groups. So number one, they have to have a high risk condition, and that's my next slide. In other words, they would have to qualify for the monoclonals the same as if they would have to qualify for the monoclonals if they were sick. So they have to have some high risk condition. So a healthy, fit, 20-year-old with a BMI of 18 is never going to get it. So number one is you have to have a high risk condition that qualifies you anyway for monoclonal antibodies. Secondly, you have to be either not vaccinated, fully vaccinated. One vaccine doesn't count. You either have to be not fully vaccinated or you were fully vaccinated, but you are immunosuppressed. So we have reason to believe that that vaccine may not have had its full response. So you have an unvaccinated person who's high risk. You have a fully vaccinated person who has a high risk feature and is on, Remicade because they have ulcerative colitis. And they have to have a close contact exposure, right? So it's not that they were in shul sitting 4 rows behind somebody. And that's the same as the traditional one, which is within, close contact, 6 feet, 15 minutes, or someplace they work, someplace where there's an outbreak. If they work in a COVID unit at a hospital, right? So you have to meet all 3 of those criteria in order to be qualified for the prophylactic monoclonals. Okay, these are the criteria. These are the high risk criteria. So this applies to patients who test positive for COVID and are being referred for treatment with monoclonals. And it refers to people who are either unvaccinated or immunocompromised, had a close contact, but they also have to have one of these. These have recently been expanded, so it's quite easy to qualify. Anyone over age 65 always qualified. The BMI until August was 35, which is significantly overweight. They now changed that directly from 35 all the way down to 25, which is, I don't know, 90% of America probably. So that is how most people, who are basically healthy are qualifying now. Pregnancy was added. So pregnancy, because it's known to be high risk, was added. Chronic kidney disease, diabetes, immunosuppression were always there. Cardiovascular disease, chronic lung diseases, sickle cell disease, neurodevelopmental disorders were added, as well as anyone that has something like a trach or a G tube or are on like an AVAPS at night. So it's pretty, with the addition of that BMI, it got kind of easy to qualify. Okay, so this is my summary, and it's not all encompassing of outpatient treatment, what we know, what should be given, what shouldn't be given, and how right now. So monoclonal antibodies, definitely, it's a fantastic treatment. It is only for people who have mild to moderate illness. So if you are requiring oxygen, you don't qualify anymore for monoclonal antibody treatment. Or if for people who are already on oxygen, they have COPD, whatever, if they are on higher than previously needed oxygen levels, they don't qualify. Technically, most institutions will give it within 10 days of symptom onset. I know Northwell will. Personally, all the studies were done within 7. The earlier, the better is basically it. And in people who meet criteria that have the proper risk factor. So again, with the caveat that doing this in fully vaccinated people, we do not know the benefit. There's probably no harm, and that's why everybody's doing it. But in a world where not everything is limitless, I think we should try to limit it to the higher risk vaccinated people. Like I said, I had a cousin who's a healthy 50-year-old with a BMI of 25.2, no medical history, went for MAB. I would not have recommended that personally. I mean, he was going to be fine without it, and so that's not it. Keys to the outpatient treatment are fluids. Patients are coming in dehydrated all the time. That was one of the main things we learned at the very beginning. Fluids and more fluids. And also not just plain water. We actually see a lot of hyponatremia. So you want fluids with electrolytes. Acetaminophen alternating with NSAIDs. That's what I usually recommend, unless they have contraindication to either. You can absolutely use ibuprofen during COVID, unless you have a reason to believe that they're in kidney failure, they have bad stomachs. I personally like to alternate them because you also get elevation in your liver, LFTs, when you have COVID. So I like to alternate them. And monitoring pulse oximetry is something, obviously in the young and really healthy teenagers, I'm not doing it, but anyone who's at a little bit of a risk and certainly who's nervous, anyone can get access to a pulse ox. I find that very helpful. Some key points, dexamethasone or any other steroid is not indicated in patients with COVID unless they require supplemental oxygen. In fact, it was actually shown to be slightly detrimental. So if you're starting dexamethasone on a patient, the patient should be on only should be on patients who need oxygen. If you have a patient who is an asthmatic or COPD, and now they have COVID, just like any other respiratory virus, can of course exacerbate asthma or COPD. So if your patient is the type of patient that every time they get a cold, they need to go on prednisone because they have an exacerbation, then they may need to go on prednisone, but you're not treating the COVID there. You're treating the asthma or the COPD exacerbation, to be clear. And then you're using the standard dose of prednisone. You're not using dexamethasone. Inhaled corticosteroids, your Advair, your Symbicorts, your Brios. Again, I usually use in patients that have a bad cough that I suspect have some form of reactive airways going on. And so that's the appropriate patient. I'm going to save the role of anticoagulation for a minute. Please, I don't know the practices here, but there's no reason. I mean, I still have people who are getting Zithromax from urgent cares all the time when they have COVID because, oh, I have pneumonia. Yes, you have pneumonia. It's a viral pneumonia. There is no role for azithromycin. There is no role for hydroxychloroquine, and there is no role for ivermectin. I'm not even putting data up because there's just overwhelming. And if I had a single positive study to show you, I would. The role of anticoagulation is something that I am looking at very closely in my program. Somebody posed a question before about giving aspirin or baby aspirin in COVID. So the answer is that as of now, there is no evidence, and certainly no study, evidence-based medicine evidence to using aspirin or any other form of anticoagulation in treatment of outpatient COVID. I put a little asterisk by it because in my, the program that I run, and I'll go through what I do, is that I'm taking patients who normally would have been admitted to the hospital and treating them at home. So I have a slightly different algorithm because I'm, if not for this, they'd probably be on the floor in the hospital. And so I like to mimic what was there. So there is no evidence that using aspirin or anticoagulation shows benefit. That being said, when I have somebody that's really, really nervous and I want to, if you don't have a contraindication to take a baby aspirin, you take a baby aspirin for 30 days, there are worse things, but just know that there's no role, there's no evidence for that whatsoever. Sometimes it's more of a placebo effect. Okay. Coming down the pipeline, and one of this is very exciting. So we've been doing this since December, but remdesivir, actually, the Veklury, sounds like a Marvel character, recently is putting out their preliminary report of using their IV remdesivir. Remdesivir is only given in the IV at early on in disease, pre-hospitalization, and they actually found that it decreased the risk of hospitalization in high-risk patients with COVID. My CROWN program, as far as I know, is actually the only one not in a study. We've actually been giving home IV remdesivir to patients who, since January, off-label use. So I'm very happy to see that. And we published our results too, which was great. And then, of course, I'm sure everyone is kicking themselves for not buying Merck stock a week ago. Merck is now, it's all over the news. I don't have any information about this than you do about their new wonder drug, which is they're saying is basically Tamiflu for COVID. It's a pill, it's an antiviral, you take it on early in disease, and it decreases your risk of hospitalization or death. And they are going to be applying for FDA approval. So that, of course, if that really works and they get it, will be a game changer. This is just a quick summary of what we do that explains why we're a little bit different. So our CROWN program is a comprehensive, really comprehensive home-based treatment for moderate to high-risk COVID patients. This was started in April 2020 when there were no hospital beds to be found. People said, there's no way, anyway, I'm going to the hospital. People were dying at home. They were not getting the right care. And so we started this. But our program is telehealth visit daily, sometimes, depending how sick they are, with pulmonary and critical care physicians. It's a home nursing visit on a daily basis that our nurses go into the house, home labs, home IV, home oxygen. We give them dexamethasone. We give home IV remdesivir to appropriate patients. And we kind of mimic home anticoagulation. Basically, our program provides at home for these patients everything that they would be getting on a medical floor in the hospital, because otherwise they actually would be in the medical floor in the hospital. And we've actually done a fantastic success with this, and we've kept hundreds of people at home and treated them successfully. And we also then gain their trust that they believe that we're not just saying, go to the ER, so that if they actually do get sick, when we recommend, listen, now you need to go to the hospital because I have reached the level. When I tell them my goal is to keep you at home, and if I'm telling you you need to go to the hospital, there's a little bit more trust when they realize that everything has been done, and staying home could certainly be deadly. What's new for inpatient strategy, just for 2 minutes because I'm running out of time. A couple of new things that were very interesting for the inpatient strategy, and one relates to me. Last month, the New England Journal of Medicine published 2 very interesting articles about therapeutic anticoagulation in COVID patients in the hospital. And the summary was that in the non-critically ill patients, so the patients on the floor, giving them therapeutic dose heparins, basically Lovenox, therapeutic dose, in the absence of a clot, even with a normal D-dimer level, and even more so with a D-dimer level just over 2 times the upper limit of normal, actually improved survival to hospital discharge. So, you know, whereas giving therapeutic anticoagulation in the absence of a documented clot in the critically ill patients in the ICU actually showed no benefit and actually showed an increased risk towards bleeding. So exactly why that is that clearly if you catch them early in the disease, is it because you're preventing clot? Although some of these patients had a normal D-dimer and they still had a good response, does that mean that there are some properties of the heparin or the Lovenox itself that is anti-inflammatory, that is antiviral, and that by the time we reach the ICU, it's too late? We don't know the answer to that. This is the reason I'm considering in my particular program doing this for outpatients. But this is just what's new in the inpatient world. The other thing that's new, well, it's old and new again in the inpatient world, is the IL-6 inhibitors, specifically tocilizumab. You know, originally at the beginning, we were using toci. It made a lot of sense. We were following markers. Then we found the patients were becoming fungemic and they were dying of sepsis, and actually they were not doing any better. And so it totally fell out of favor because it was killing more people than it was saving. Then some new studies came to light, which basically showed that, again, in the same New England Journal, if they were hospitalized just with severe pneumonia, toci did not show any benefit. However, patients that needed ICU treatment with organ failure did show treatment and did show improvement. And so pretty much tocilizumab was reintroduced, but only for patients that were failing other measures and required transfer to the ICU. So for 2 seconds, if you're interested in seeing, this is our very basic current Northwell inpatient algorithm. You know, basically basic stuff: oxygen, everyone gets remdesivir, everyone gets dexamethasone. If you, despite getting these 2 drugs, progress to needing high flow nasal cannula, intubation, ICU with organ failure, then you get a dose of tocilizumab as well. And as far as inpatient anticoagulation, we're now considering, you know, automatic therapeutic Lovenox for patients on the floor, but not for patients in the ICUs in the absence of a documented clot. And then this is actually our post-discharge prophylaxis, which you might see more. We are doing for patients depending on their VTE risk, which we calculate 30 days of either rivaroxaban, either Xarelto or Eliquis prophylactic dose for 30 days, or baby aspirin for 30 days post-discharge, depending on their risk clot and their renal function. I put one slide in at the end here. It's sorry that I'm going over time, Leora. Sorry, there was just a lot to say. Acute COVID-19 and the post-COVID conditions, post-COVID syndrome, long haulers, whatever you want to call it, which this top box is from Up to Date. I really just copied it from there, so I'm giving them that. But they're calling any symptoms that linger for after 4 weeks. And the key point is in yellow: whether the constellation of symptoms and persistent issues experienced represent a new syndrome unique to COVID, or there's just overlap with the recovery of any other infectious or critical illness, has not yet been determined. I can tell you where I fall on most of these. And obviously, people who are very sick in the hospital are going to take longer to recover. The bottom is what I see. Okay, so common complaints, and most of these are very subjective: fatigue, shortness of breath, chest discomfort, headache, memory loss, concentration issues, insomnia, anxiety, palpitations, hair loss, and anosmia. Those are actually, that's not as subjective. And then there's what are objective findings and what are we actually looking for. So there are certainly things that are post-COVID. Some are unique to COVID, and some are, again, going to be related to any hospital admission for severe pneumonia or ARDS. So the dysautonomia syndrome is something that is real. This happens after mild COVID. It's very rare, but it is very real. About patients post-COVID, their COVID wasn't even so bad. Suddenly, their heart rates are fluctuating very high, very low. Their blood pressures are dropping when they stand up, basically postural orthostatic hypotension syndrome. It can be very devastating. There are specific therapies for it. And this is something that we're seeing post-COVID. Again, rare, but we're seeing it even in young, healthy people who had a mild disease. We're working other people up. People are coming in with coughs. Again, a cough, before COVID, I always joke, I used to make my living on people who had coughs that persisted more than a month after they had any viral illness. Having a cough 4 or 5 weeks after a bad viral illness is nothing special to COVID, in my opinion. I see it all the time. We're working people up with pulmonary function tests. They're getting chest x-rays, they're getting CAT scans, they're getting stress tests, they're getting Holter monitors, they're getting neurocognitive testing, polysomnography. And obviously any patient that had a severe pneumonia or had ARDS is going to have post-ICU syndrome from any disease. If you had a bad pneumonia or ARDS, you may have post-ARDS pulmonary fibrosis from any disease, not specific to COVID. Many, and the vast majority of the patients that are referred to my practice with these symptoms, these subjective symptoms months after COVID, we find no objective data of anything wrong. And in many cases, people have slowed down. They were sick. They were very sick. And so they slowed down. They were not as active. They gained a lot of weight. Some developed sleep apnea. And then they kind of thought that one day they'd be able to snap their fingers and turn around and go back to running the mile that they could before. And sometimes the expectation is just unrealistic. So there are definitely things that are there and that are real. A lot of it, though, has nothing specific to do with COVID. A lot of it is anxiety, and a lot of it is just post any viral illness. And what I've been seeing personally, I'm not discounting that there are real post-COVID syndromes, that there are real issues with neurocognitive. I just don't think that that's the most common what's going on. So in summary, Delta is now the only significant variant causing infection in our area. It's more highly contagious, but has not fortunately been shown to be any cause more severe disease. The vaccines are still, despite all the breakthrough cases you're hearing of, very effective, 10 times at least effective in preventing breakthrough infection, and certainly extraordinarily still effective in preventing severe disease. Vaccines decrease the reinfection rates, even in those with prior COVID. The boosters will improve the vaccine effectiveness even more. We've seen that in Israel tremendously. Monoclonal antibodies is a highly effective treatment for COVID infection and for prophylaxis in the right people that we discussed, although its benefit in vaccinated individuals remains unknown. And other outpatient treatment options are looking promising, and hopefully this will become an endemic disease that is treatable and we can all go back to normal. And that's it for me. Sorry for taking so much of your time.
Not at all. Thank you so much, Dr. Lisker. I think I speak for everyone saying this was a very informative, relevant, and helpful presentation. So let me look in the chat to see questions. And if anyone still has questions, please feel free to unmute yourself or to type it in the chat. Okay, so what is the data on fertility in men post-COVID?
So yeah, I mean, that is something that was looking for sperm counts specifically being decreased. I'd have to get you that. And again, they most likely recover. I'm not trying to say that there's an epidemic, going to be an epidemic of male infertility after COVID. It's just a foil to the only thing that has been found in fertility is that nothing in women. So I don't think it's causing long-term male infertility issues.
Okay, thank you. Next question. How soon after monoclonal antibodies can someone get a booster vaccine?
So you have to wait, after monoclonal antibodies, you have to wait 90 days to get a vaccine or a booster.
Is there any room for post-vaccination infection antibody testing? Sorry, is there any room for post-vaccination antibody testing and or infection to guide decision-making?
Great. Actually, I'm glad you asked that because I forgot to actually bring that up. So the answer is no. We are not recommending antibody testing. What your antibody testing is the spike antibody, not the neutralizing antibody levels, which is a different test, which is only being done in studies. I will tell you, and actually we're currently in the middle of a study that I'm heading, looking at the vaccinated admissions to all of Northwell, about half of which were not admitted for COVID. It should be noted. It's just that everybody gets admitted, gets tested. So if you fell, broke your hip, and you got admitted and you tested positive for COVID and you were vaccinated, you counted as a vaccinated admission. But I will tell you clearly from my experience and clearly from others, because that's why it's not recommended, I have people getting breakthrough infections with spike antibody levels greater than 250. It's not reflective. Your current spike antibody level does not reflect whether or not you can get a breakthrough infection.
Interesting.
Actually, at the beginning, when breakthrough was happening, I was checking it routinely because I was interested, and
Mhm.
they were always high. I check it sometimes on my immunocompromised patients just because I'm curious. It's been high. It is not reflective. So, well, it is not, there is no role. It is not recommended to check your antibody levels in order to make a decision about whether to get a vaccine or a booster vaccine.
Okay, thank you. And then Rifki wants to know if there is a difference for COVID positive pregnant women when it comes to taking aspirin, if there's any evidence at all in terms of.
Not to my knowledge. I do not know of any. I would ask pregnant women specifically to talk to their OB, but I have not seen or heard of anything specific to pregnant women with aspirin.
Okay. Okay, so if no one else has any questions. Good. Okay.
A lot of information, sorry.
A lot of information. Thanks again for your time, Dr. Lisker. Thank you everyone for tuning in, and have a good evening.
Good night.
Night.